Welcome to the Redefine Health Ed podcast. I'm your host, Dr. Katie O'Bright, and we're going to talk all things primary care PT. All right, hello, everybody. This is episode 10 of the primary care series of the Redefine Health Ed podcast. I'm your host, Dr. Katie O'Bright, but y'all know that by now because most of the people that listen to this podcast are the same people that have been listening to it from the start. But hopefully we'll get some new ones here and there. So today on this episode, I have a really great guest who's going to share a little bit about his experience working in a variety of different settings, from the emergency department into different primary care spaces and different settings. So I have the pleasure to introduce Dr. Stephen Goostree, who is a physical therapist. It sounds like born and raised in the Chicago Metro and currently lives in Chicago. So Steve, thanks so much for coming on today. Tell us a little bit about your background.
Sure. Yeah. Thanks a lot for the invite, Katie. So I've been a PT now for about 11 years. Started out actually as a PT assistant. Born and raised in the Chicagoland area. Did my undergrad down at Southern Illinois University. Go Dogs. So I was studying, my bachelor's was in kinesiology, but then I'm like, all right, what am I going to do with that after I graduate, right? So they actually had a really strong PT assistant program down there. So kind of joined on with that my junior year, and since that was a 2-year associate's degree, was still able to graduate in 4 years with the BS in Kines and the associates in PT assistant. Oh. So then went on to work as a PTA, and I knew long-term I wanted to either go back for my DPT or I was interested in physician assistant. I think it was in my blood. I like to tell people my grandpa was a surgeon, my grandma was a nurse, my mom was a nurse practitioner. So, it was just in my blood. So, yeah. So then went to, I worked for kind of a satellite clinic for the Rehab Institute of Chicago, which is now Shirley Ryan Ability Lab. Had some awesome mentors there and worked for a PTA for about 2 years. And they're like, Steve, you got to go back and get your DPT. So I said, all right, great. So there was, at the time, it was sort of like a bridge program for if you were already a licensed PT assistant with a year or two of experience. They, highly encourage you to apply. So that was Franklin Pierce University out in New Hampshire. So that was one of the first schools that I applied to and got accepted to. So I'm like, all right, let's, so competitive, right? So I'm like, let's do it. I was super pumped too, because one of my mentors still, and he got me really interested in orthopedic manual PT, especially was Dr. Josh Cleland.
But of course, I was, as soon as you said Franklin Pierce, I was like, I wonder if he was there when, yeah.
Yep, certainly.
Josh Cleland, now I'm adjunct faculty at Tufts, and Josh Cleland is one of their core faculty members now. So awesome, always awesome to get super shout out to Josh Cleland for being inspirational to us all, decades past and decades beyond. Go ahead.
Certainly. No, that's awesome. The more I, the practice, it's crazy how small the PT community really is,
I know.
So that was great. Got to really kind of study under Josh. During my third year, he actually created a manipulation elective. So that was awesome. I actually enjoyed going to that versus like a peds, lecture or something.
Yeah.
So then graduated from Franklin Pierce, had a fun couple years in New England, but missed Chicago, so moved back, and then started working just as a staff PT, outpatient ortho setting. I was really interested in doing an orthopedic residency, but I knew long-term I wanted to do fellowship as well. So I even had a few conversations with Josh about that. And luckily he knew at the time the program I was interested was at the University of Illinois, Chicago. Mm-hmm. That was headed by Carol Courtney, and Josh and Carol are buddies. So Josh actually told me, he's like, get the required amount of, hours that you need to apply for the fellowship. And he's like, dude, at this point, just skip residency, just go straight to fellowship. I said, wow, okay. Mm-hmm. So with a super stellar letter of recommendation from him, got into the OMPT fellowship at UIC, which was awesome, game changer, just made us super competent and confident in treating the complex orthopedic patient, which was awesome. So after that, did a little bit of mentoring for the fellows in training and some of the DPT and stuff like that. So since then, had a variety of different roles. I like to make fun of myself now that I've been a job hopper in the past, which,
Nothing wrong with that.
Our parents, they stayed at the same job for 40 years, but I feel like that's like unheard of now, right?
Mm-hmm.
So it was pretty cool. Once I got my DPT, some of those former mentors that I had when I was a PTA said, hey, we're starting this new pilot in the emergency department, and we feel like you would be a really good fit. Little bit of background there. That was my mom's background. She was in emergency medicine for 30 years. And she had made me like a CPR instructor and things like that. So I was always in the back of my mind, I'm like, I really like the ER. I like the primary care setting. So that was really cool. So what that entailed, you go in for your shift, and we had a small little treatment room, and we would basically be performing triage in the ER. So that would free up the ER docs and their nurses' schedule for the real complex cases, stabbings, gunshot wounds, stroke, things like that.
Yeah.
And all the MSK would then come see me first for a consult, which was super cool because, as we know, a lot of spinal pain, neck and back pain is mechanical in nature. So that was really where my mobilization, manipulation, clinical reasoning skills came in handy. Repeated movements. We could get somebody, walking in with a 10 out of 10 pain. I could perform a quick manip if they were appropriate, and they'd walk out, their pain had, cut in half, and they didn't need any unnecessary imaging or pharmacology, stuff like that. So that was super cool. Had a really nice close working relationship with the ER docs and the nurses. So they're like, oh, see Steve first if it was anything MSK related. Didn't really do any wound care, but did some assistive device training if somebody was living in a nursing home and they had just had a fall and then went to the ER to rule out a hip fracture or anything. Do some basic gait training and stuff, but most of it was MSK, which was super cool.
Isn't that so cool? So I think that, the ED obviously is emergency care. People go there if they are having an emergency or think they're having an emergency. Whereas primary care is more, outpatient, long-term relationships, sustainable relationships. But I honestly think that the way that PTs are utilized in both settings is very similar, because most of the PT models that are out there for primary care in the ED, the physical therapist is really serving as a consult expert in functional needs. So in neuromusculoskeletal conditions that are coming in for the first time, what does this patient need? Does this patient need imaging? And if so, what kind? Or does this patient need to be seen by a specialist? Is there something really concerning going on? Or might they just benefit from a couple of, manual therapy techniques or, some education and reassurance that they have the good prognosis, which is most musculoskeletal pain. So I think that that's a great perspective that you kind of started out that way. So keep going. Tell more of your story.
Sure. One more thing about that role, that was pretty cool because then I would have basically the front. So there was an outpatient ortho, our same hospital-based outpatient ortho clinic was across the street. So I would do my, quick 15-minute triage. And then if they had the time and they were open to it, I would get right on the phone with the scheduling folks across the street, and a PT, if they had an opening, could see that patient right away. So it was awesome. It was just like I captured them in the ED, right? And then they just went across the street.
Well, and that's really solid too, because if you think about it, a lot of patients that go to the ED, they receive advice where it's like, okay, follow up with your primary care provider, or, call the orthopedic surgeon's office and have them, get an appointment with them. And then the patients are like, there's this, sometimes the patients don't know if that is the right thing indeed, or they don't follow up, or they don't do this and that. And I think it's a really solid thing where you can have that intricate connection with somebody to actually say hey, here's this. I really think that you would benefit from at least a couple of visits, or maybe just even a one-time more comprehensive assessment, go get involved. And then the patients are a lot more likely to follow through and then not have recurrent episodes where they land back in your care again. So I think that that's awesome. And that's something that I think in one of the other episodes that we talked about, which I just published today, Rebecca Griffith's episode, where she talked specifically about, the connection between providing care in the ED to providing care in the primary care PT space. It's really important. It's really important to facilitate and help the patient gain that understanding of what they need to do next. Not only gain the understanding, but actually help them facilitate that. I think that's awesome that you were able to do that. Can you comment a little bit, because another feature that has been continuously coming up is once other practitioners in these team-based care settings, so, you were in this sort of team-based collaborative emergency department, and other practitioners got to know you and got to know what you were capable of. A lot of other PTs that we've interviewed have said things along the lines of, once we were there, you can't leave, because the providers understand your value and they become almost dependent on you. So can you comment on your experience with other professionals when you first started out, and then kind of towards the end of your tenure there?
Sure. Yeah, that's a great point. So at first, I feel like I almost had to prove myself to them, right?
Yeah.
So it's like, all right, these ER docs are super experienced, or the nurses, or they were probably wondering at first, what's a PT doing in here, right?
Mm-hmm.
So, but then, yeah, after they saw how I interacted with patients, and sometimes then they got really interested. They're like, oh wow, this guy's, I want to see what he's doing. So I would actually have some of the ER docs like sit in on my consult.
Mm-hmm.
And it was just, that's what really got me interested in like the collaborative care model, was getting that well-deserved respect that we certainly need as, DPTs.
Yeah.
I remember what got me a lot of clout, I guess, in the ER. I had a really interesting patient. She came in with complaints of low back pain, looked pretty MSK in nature just from the intake and stuff. But with all the physical exam testings and everything, I couldn't reproduce anything. And she was just constant. So I'm like, all right, this sounds a little more visceral to me. So then it was great to have the trust from the ER doc, because then I actually recommended, hey, I think this person should go in for imaging like ASAP. Mm-hmm. And the doctor came and found me like 2 hours later, gave me a huge pat on the back. He's like, Steve, great catch. This individual ended up having an ovarian cyst burst. Mm-hmm. And then it was just mimicking low back pain.
Right.
So she actually ended up going into surgery, and, same day. So I would say that was a big win. And then after that, all the nurses would be looking for me, that they, like, we got someone with neck pain in the waiting room, someone that just fell off their bike with shoulder pain, ankle sprain. So then I became super popular after that. So it was pretty cool.
And that is exactly the way that it should be. And as somebody who personally has had, personal experience with endometriosis, the time that it takes to get to diagnosis is extremely long, years for most people. So if you're able to identify something like that early on, oh my goodness, you would save people a lot of hassle, a lot of trouble in their quality of life, a lot of time and money. So kudos to you, and very much appreciate that. So yeah, go into a little bit about how you ended up your time in the ED and then moved into more of the primary care setting.
Sure. So yeah, after that ED pilot, which I hope is still going on. I hope it's a full-blown.
So this was a pilot. Are you able and willing to share where that was?
Yeah, sure. So that was at Alexian Brothers in Elk Grove Village at the time.
Super close to where I'm at. I'm in Palatine, so I know exactly where that is.
I think since I've left there, I think they've merged with another group, or I think it's Ascension now.
Ascension, yep.
So different name, but yeah, that was awesome. It was actually the hospital where my mom had worked. So people knew my last name and stuff too. And so then it was kind of cool being recognized. They knew my mom, and some even knew my grandpa and stuff like that. So that was super
so cool. Love it.
The main reason I kind of gave that up was just because the commute. I was living in the city at the time, and just
Ah,
I was kind of just doing that PRN anyways. So getting to and from Elk Grove Village to back to downtown was getting a
that
bit tricky.
that can be gnarly. For those of
Right.
you who don't live in the Chicago metro, we have gnarly traffic. Gnarly. It's, I mean, an hour to go, 10 miles. So yeah, gnarly. Yeah, I
Yeah.
totally get it. Okay,
I
so
think
moving on.
I think we just got rated the #1 worst traffic
I
state
saw
or
I saw
city
that,
in the
which
country.
I was surprised by of all the cities. But now after living here for a while, like we avoid going to the city because of the traffic. So I
Sure.
get it. I get it.
Yeah, so after that, like I was saying, did a little bit of job hopping, a lot of private practices, had a couple manager positions, senior clinician, things like that. And then this primary care role opened up. So it was a startup company that started as like a tech only company based out of New York City. So it was mainly physicians and then PAs and nurse practitioners that would treat folks, digitally, virtually. And then they opened a couple offices in the New York City area, New Jersey, and then Chicago was the third on the list. So it was pretty cool. I started on with the group when they hired on. It was a physician, a few PAs and NPs, a behavioral health specialist, and then myself. And once it was interesting, we were located downtown in the city in a high rise, and we basically had a partnership with one of the main employers that occupied that high rise.
Mhm.
So that was pretty sweet. I didn't really have to deal with a lot of insurance headaches and stuff that I was used to.
And I'm so glad that you brought this up. Are you, again, are you able and willing to share the name of the company? If not, that's totally fine.
Yeah. So the company was Eden Health.
Like EDEN.
Yep.
Okay, awesome. Because do you want to know why? And I'm actually working on it. And I think this is the first time I'm actually announcing it because I'm almost done with it. I'm working on a paper that's like an update in the operating models of integrated primary care PT. So all of the different types of settings where primary care PTs are actually working. And because all that we have to reference in the literature right now is an article, a paper from 2005 that only mentions basically the military, the VA health system, and Kaiser. Well,
Right.
it's exploded way beyond that. And one of the main areas or practice settings that I'm taught that I included in this article was employer sponsored clinics. Because I think between you and me and the rest of the world, I think employers are getting a little tired of spending ridiculous amounts of money going towards third party payers that are ultimately not doing anything for their patients or their beneficiaries. So employers are just choosing to cut out these third party insurance companies that, again, are doing nothing or seemingly nothing for their beneficiaries. And they're just hiring healthcare providers directly, which makes a lot of stinking sense, doesn't it? So
Right.
so keep going. I want to know so much more about this.
Yeah, so that was super cool. We were all really refreshed by that fact that we're not going to have to be on the phone with insurance companies, begging, oh, please, this guy just had ACL surgery and he only got approved for 6 visits. Like that gives me terrible nightmares thinking back of some of those
Oh my
situations.
gosh, I know.
Um,
Same.
but again, it was kind of a growing experience where I almost had to prove myself. I had to say to the like she was a DO, so she did have some manual training too, but she was super impressed with my manipulation skills. She's like, "Wow, I didn't know PTs were trained like that." I said, "Yeah, certainly, it's part of our curriculum now."
Yeah.
So that was awesome. And then same thing, the nurse practitioners would come in and they would, watch me do an eval and then treatment follow up and stuff like that. They would even come to me like, "Oh, my neck is killing me today. Can you work on it?" So we grew super fast. Like once the word got out in the building, like, "Hey, we have a primary care office." So folks would come in and get their COVID booster, and then they would come have me work on them with their knee dysfunction. And after just a short period of time, myself, I was the only PT there and I didn't have any techs or aides. It was great. It was an hour blocked off, one-on-one, undivided. So folks got better relatively quickly, I would
Wonderful.
say. And so that was really cool. And then, a lot of the nurse practitioners and the physician, and even the behavioral health, we would all have daily huddles, which was great. We would talk talk about, we were all treating the same person for different things, but then it was great since I had that hour to spend with the individual. I could pick up on a lot of yellow flags. So
Yes.
they'd be telling me, hey, I'm super stressed out with my job. I'm feeling a bit depressed, things like that. And as soon as any of those conversations came up, I would ask their permission. Hey, we do have a behavioral health specialist in-house here. Would it be okay if I shared your information with her, and she might reach out to you if that's okay? And more than not, most members there were super pumped because it was like a one-stop shop, so to speak.
And this is the whole idea. Like, this is the whole idea of team-based care and how and why it's so important that we are co-located, which you can practice your primary care philosophy if you're independent and not co-located. You can. I want to reiterate that so hard. But I will say that when you have a patient in front of you that you notice is struggling and this goes for like the physician side too. So for example, if I'm a physician and I'm working with a patient and I can really tell that they're having trouble with their functional movement, with getting around, or they're saying that they're in a lot of pain, how easy is it for me as a physician to go and grab the PT that is right outside my door or in the office somewhere and be like, and then, do that warm handoff, just bring them in and introduce them. Whereas a lot of patients, and this has been my experience when I've done like site visits and I've shadowed physicians, if they introduce the concept of physical therapy, a lot of patients are like, no, I don't want to do that. And honestly, my belief is because the general public thinks, and unfortunately, this is still the case in a lot of places, if you go to physical therapy, you're going to have to spend 3 times a week for 8 weeks. And it's a lot of time and money. And people don't have, first of all, it's not necessary. And we should not be promoting that insane volume of care that is entirely just for business purposes, and it is shameful and fraudulent. And I will shout that from the rooftops because it frustrates me to my core.
Yep.
But anyway, before I go off on a tangent, I will say, like, how easy is it to like bring a physical therapist in that can meet you, you can put a face to the name, get care established, and not have to do this insane, try to find a PT in your area. You got to wait a couple weeks to get in there. And then, by that point, you're like, I don't even feel like I should go anyway. Or it is just so important and so awesome that in a team-based care setting, if you have a behavioral health need and you have a person on staff, you can bring them right in. They can do a quick little triage assessment. The patient gets buy-in. They have better access to care right there. This is my vision for all of primary care. And again, shout it from the rooftops. And it is so cool that you got to experience that with Eden Health. Now so contrast that with other care settings that you were in, because I heard in there, which we didn't harp on yet, heard in there you did a little job hopping. I've been there too. And probably a lot of other people have as well. So I'm curious, if you could just comment on a little bit of that, and then we'll talk about where you're at now.
Sure. So one of the things that it almost drove me out of the PT profession was the, insurance dictating patient care. Or like even the higher ups were saying, you need to see this person 3 times a week for 6 months. And I'm like, certainly not. That's not, based on my exam, they do not need that. That's overkill. That's fraudulent, in my opinion, so
shameful and fraudulent.
Right. So that really used to upset me. So then I'd start looking as soon as, all that pressure came on to be super productive. And then I had this on the side. If I had a free second, I'd have to get on the phone and do cold calls to physicians. And so I'm like, this is just silly. So, so then I'd go, I'd interview with a different mom and pop shop. And they'd promise me the world, right? Like, oh, we don't do that here. And it was like the same shit, different day, basically. You'd go to that clinic, they'd treat you like a prince for, maybe the first week or 2, but then you started like, nope, it's the same stuff in a different location.
And I harped on this in the last episode that I did with Dan Kang and Jeff Hauk. They're in Providence Health. I told my story about my first job engagement in Chicago. Took all of 5 weeks for them to, and this is crazy. they actually flat out fired me on the spot. No warning, no conversation. And I was as diplomatic as I possibly could be about, no, I'm not going to do that model. This isn't what we talked about at my interview at all.
Right. Yep.
I'm not going to see a patient 3 times a week for 16 visits if it's somebody with a very simple thing that only needs a few, like, I am not going to commit fraud on your behalf. I'm going to do what's medically necessary for the patient. And I tried to harp on that. And I even went to the extent of, I will help you build out your cash services and your wellness services so that I can, make sure that the revenue that I'm bringing in is consistent with what you're looking for. Nope. They came in one day and they fired me.
Oh, wow.
And they said it was because I was doing all of these other terrible things for their business. And yeah, so and now since then I have explored what other like corporate clinics are doing in this area, which really hard to find mom and pop shop nowadays because they're all getting gobbled up by these private equity firms that are running healthcare. That's another problem, not just insurance companies, but private equity firms running healthcare.
Yep.
Sorry, but private equity, their bottom line is revenue. So if profit is what dictates your care, guess how many times a week you're coming to physical therapy? Again, getting off my tangent here, but how different of a world would it be if across the board in primary care, we had these team-based settings where we could perform healthcare the way that it's supposed to be done, for the benefit of the patient, for the benefit of the provider, for the group that works together. We're all a team. So right. I'm not even sure how I got on that, but I'm like, I was on I'm totally following your experience because I had that same experience and I won't ever return.
Right. No, since the last, few jobs that I've had, and I've actually really enjoyed, and a lot of them are like a primary care setting or collaborating at least with other healthcare providers. Mm-hmm. I'm never going back to the traditional brick and mortar outpatient. I feel like that is just such a broken system right now.
It's dying. Like I really, really feel that in the next 10 years, those clinics are going to start to disappear. And I don't think it's a bad thing.
Right. And if you even step into one nowadays, like they're on every corner in Chicago, right? So if you go in there, it looks like every PT that's treating still is probably 30 or younger. And then, I feel like they start there and then they start learning all the, kind of the negative things that come with that. And then they look for something else pretty quick.
But isn't that terrible? Because this is one conversation that another, separate topic conversation is we are teaching our DPT students the right way to do things in school. We are, because I've been adjunct faculty in a number of different places, even from my experience at Temple University, shout out to like the best university ever. They trained us very well and very responsibly. But the problem is when students start going out on their clinicals and they start getting their first couple of jobs, the reality sets in of this business model that is just pushing us and driving us all to burnout. And so you're totally right. If you go to any of these clinics, the vast majority of the clinicians that are going to be there are new grads within their first 1 to 5 years. And the smart ones are going to get out. And sometimes they're going to get out of the profession altogether, which is not a good thing either. So how do we break this cycle?
Right. Yeah. So I feel like we need to, a couple of things that I've learned from collaborating. It's always impressive, or I guess cool to see other healthcare providers. They really have no idea like our scope and how much they're like, wow, a lot, not just about MSK, but like when I was in the ED, visceral things and, other medical conditions and stuff. Mm-hmm. And then kind of getting away from the insurance model and trying to collaborate with like employers and stuff like that. That's where I was with Eden. That's where I am currently with the digital startup.
Yeah, and, tell us. So that's a great segue. Tell us more about that.
Yeah, so that was pretty cool. At Eden Health, I did it was kind of hybrid as well. So I was doing mainly in-person care, and it was funny. I was the busiest provider in that small little office. So sometimes, the doctor and the nurse, they'd be playing chess or or something. And I'd be back to back with patients, but it was a good thing because I still got an hour one-on-one with them and stuff. But yeah, it's just super cool to collaborate with other professions and then get that respect that I feel that we deserve. I feel like we have a terrible branding problem as PTs, and we know a lot of stuff and we can help a lot of people, but it's taking way too long, I feel. Mm-hmm. So then at Eden, I was doing a little bit of telehealth. I'd gotten licensed in multiple states. So then I would do, let's say, a telehealth visit, then an in-person. So that was kind of cool. And I started enjoying telehealth a bit more. And this was kind of right in the middle of the pandemic. So I'm like, wow, as a classically trained manual therapist, right, I was able to still help people with just education and the right exercise therapy. And I was still getting really good results, which was pretty cool. So then I saw my current role open up, and the Eden Health wasn't perfect, but I don't want to knock anything about it. But I really like that telehealth model. So I've been with this company now for a bit over a year, and started just telehealth. So just doing the virtual visits. Again, we partner with employers. So I don't have to deal with the insurance nightmares anymore, which I don't think, again, I'll probably never go back to an insurance-based company. And what's been really cool is, so this is a startup based out of San Francisco. So before it was New York, I'm right in the middle of it, San Fran. It's interesting how things work out. And now what we've just rolled out in the last month is, and I'm kind of the lead PT on this, is doing house calls.
Yeah, that's so cool. I love that.
We call them innovation partners. So they basically have us as a benefit, so they can do a video visit if they want. We collaborate with health coaches. So I'll do the eval and I'll follow up with them, but then the health coach is just, kind of like their cheerleaders saying, hey, I see you haven't logged into the app for a couple of days. How's everything going? So that's kind of nice. We have physicians, nurse practitioners on staff as well. They're more of, we call it EMO, the expert medical opinion. So again, if I had a really tricky case and I'm like, hey, this doesn't seem neuromusculoskeletal, I could easily hop on a chat with one of the on-staff physicians or nurses and talk about that member.
I've come across a number of individuals, which I'm very forward thinking. If anybody knows me, like I'm way more progressive than a lot of people. But I think even I had a little bit of, I won't say concern, but just like apprehension about telehealth. And then I actually, as a patient, had to do a couple of telehealth visits, and it made a lot more sense for me. It made a lot more sense for me and my lifestyle with my kids. And like, we live far away from where we're supposed to go. And it just made so much more sense. And it was very effective and very efficient. And at this point, I really prefer it as a patient. And so I fully support that. And I think that a lot of PTs they're really like over the top concerned about telehealth, like ruining the profession. And I don't think that that's the case. In fact, I think that telehealth is just a means by which we can accelerate the access to what we're doing. And we need not slow it down. I really feel like there's going to be a really solid marriage between the digital health world and the in-person, tangible, like hands-on sort of worlds that there's going to be this awesome marriage going forward with this. And I think we're going to have the opportunity to provide care to more people than we would if they had to call and schedule and drive and commute and get to us. I just think there's so much potential for it. So tell me a little bit about like how that works. Like, is it a per member per month, like the employer? Because people are always interested in kind of like how it actually makes sense. And there could be some employers listening to this podcast. So is it like a per member per month sort of thing set up, or how does it work?
Yeah, I hope I'm not messing up here. I don't know the exact logistics, but we have a whole business team that deals with most of that. But from my understanding is we kind of sign a contract with what we call an innovation partner. And then it's based on how many employees they have and things like that. They work out. I'm pretty sure it's a fixed price. And then it's an option as a benefit to the entire employee.
Isn't that awesome? So my husband's in general management for a large manufacturing corporation, and he has something similar. Like, so instead of us so we have our like insurance plan, which is garbage. We never use it. So we pay like the lowest price for whatever they give us. But then his employer also has these other like virtual options for, I can't remember the exact ones. I don't think it's MD Live, but it's something like that, where if you have something like an infection come up and it's obvious, like you have pink eye or, something like that, then you can do that instead of having to call and wait and do all of these things. And same thing for physical therapy. I believe there's a physical therapy option as well. So
Awesome.
comment on your experience about like how it works, some of the cases and patients that you've treated, and just a little bit about that.
Yeah, so it's been super fun. I always like to tell my coworkers and even my family and stuff. I'm like, yeah, this is the best like work-life balance as a PT I think I've ever had, which is saying a lot.
Right.
And again, at first I was kind of weary because I'm like, oh man, I'm a amped fellow, and I'm used to getting my hands on people. So there was a bit of a learning curve going to strictly telehealth, but yeah, our feedback has been outstanding. We're able to reach, like you said, folks, maybe even in rural areas that there's not a PT that's within an hour drive, stuff like that. So the feedback we're getting is how easy it is to join on, how accessible. And I've even had folks send me personal messages saying your care was like outstanding. I'm never going back to a brick and mortar clinic ever again.
Mm-hmm.
So that's really, really nice to hear. And honestly, I think the way of the future of moving forward are going to be these hybrid type models. Since our other healthcare counterparts, physicians, nurses do a lot of telehealth, as well as in-person visits. I think that's where we're going to head as well.
Yeah, totally. So when I lived in Pittsburgh, I had a mobile cash-based practice. So it's a little different. I definitely think that the cash only market, as somebody who's worked across the spectrum of healthcare, within the military where everything is free, and the insurance market, and then cash. I definitely think that if you have a cash only market, and my cash-based people are going to crush me for this, but I believe it's true as somebody who owned a business in this space. I was primarily working with, hang on one second, something just popped up on my screen. I was primarily working with people who had expendable income, and that bothered me. And because even people who are, working class, who may have a little bit of expendable income, they don't necessarily have like all of this cash on hand to be able to afford all their healthcare out of pocket. So I do think that something like this, where it's sort of employer sponsored, even if it's a 50-50 kind of deal, would be so valuable and so awesome. Because the cash-based mobile market was like, I would go and take my stuff to a patient's home and see them there. And then I also did some telephone consultation. I did have like a texting line for my patients, so it was easy for them to like drop questions in if they needed to. No barriers, no hold times on the phone. So I love that this is basically turning into like Hinge Health's model is you can do telehealth, but we also have this option of providing in-person care if and when we need to. So tell me some cases where you've used telehealth and in-person care together, or just telehealth. Like, give me some examples.
Sure. So it's kind of cool. The way we kind of break up members is either an acute program or the chronic program. The acute program is a bit newer, and currently we don't offer house calls for the acute folks. At the end of the day, the chronic members give us more business. Mm-hmm. It always comes back to that, right? Mm-hmm. So the house calls I've been doing are our chronic members who may have started with like a video visit and they're working with a coach, but they just still want a PT to get in there and it's great getting back, even just able to do overpressure on someone's shoulder, or passive accessory mobility testing in the spine, which obviously you can't do through the computer. I feel like even just delivering a super thorough physical exam just gets them a lot more motivated to part, and then easily transitioning to, before I leave a house call, I'll say is I'll make sure that they have the app downloaded and we get their exercise therapy up and running. I configure it like during the visit. And then maybe even run through a few of their exercises and stuff like that. So yeah, the feedback, and we've just recently started this in Chicago, and by the end of the year, we have lofty goals. We want to be in multiple metros and stuff like that. But the feedback we've gotten so far has been very positive.
That is so cool. And I honestly think that for that you have that option, that's really important, because for those the individuals with chronic pain, it's multifactorial, it's multidimensional. And sometimes the tangibility of that in-person interaction is something that people with chronic pain might need. Whereas somebody who's dealing with more of an acute episode, a lot of times, we know this, neuromusculoskeletal pathologies tend to be self-limiting, especially if it's the first time that they've ever had something. So if there's in the absence of any red flags, sometimes just education and reassurance and just, keep moving in a safe way is really helpful. But but individuals that are dealing with more complex comorbidities and chronic pain, it does help to have that in-person interaction from a variety of angles, whether it's, overpressure during an assessment or doing some manual therapy, like hands-on interventions, or if it's just that contextual, like, we're in the same space, I'm with you, you're with me, we're physically present together. And that makes a difference in somebody's experience, which the experience, especially for individuals with chronic pain, matters a lot. So cool. I just feel like we could continue talking for forever. But as far as podcasts go, this is where people tend to drop off.
Sure.
So I would love to know, like, if people want to connect with you for your insight on the variety of cool settings that you've been in, how can they best get in touch with you?
Yeah, they can. I can even just give out my personal Gmail. That's fine. It's just my first name, Steve, last name, Goostree. There's no E after the goose. That's a common typo. So just all lowercase, Steve Goostree at gmail.com. And yeah, I love to talk shop, huge nerd. So if anyone has any questions after hearing this, I'd love to chat.
Awesome. And is it okay that I share that you're also on a particular social media platform that we connected on?
Yeah, LinkedIn.
Okay. Yes. So Steve is also on LinkedIn, which is how we originally connected. But I will put his email address with the correct spelling in the show notes for this episode. And then you can also reach out to him on LinkedIn if and when you feel like it. Any last little parting words, any words of wisdom for people that are interested in getting into this space, or that are, maybe experiencing burnout in those crazy clinics we were referencing, anything at all?
Yeah, we're growing rapidly. So, keep your eyes peeled if this sounds interesting to you. And then, yeah, just want to say thanks to you. I'm super pumped I signed up for your primary care class in Schaumburg in a few months. So we'll get to meet in person. And now that I'm going back into folks' homes and stuff, it'll be nice to even just review an abdominal exam, for example, something like that. So super excited about that.
Great. Well, I'm really excited to have you. And if we didn't mention this already, it's Hinge Health. Hinge Health is the company that Steve works for that is hiring, and you can go check them out, give them a Google, and see what jobs are available. So thanks so much for coming on today. This was a great episode, and it'll be coming out very soon. So stay tuned. Thanks for listening to the Redefine Health Ed podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.